So we will start in, about another 3 or 4 minutes. So I'm going to go ahead and go to mute. Okay, guys, we're going to go ahead and get started. And I was seeing your chat comments there, and number one is I think that after everybody's taken the answers, is that those will be made available. But when you're checking, or if you have a question about a particular question, please don't hesitate to drop me an email. I'll be more than happy to go over the question and also go over the rationale for the answers, or possibly where you may have picked up. So the things about you are talking about the test is hard. I'm going to tell you that in pharmacy students, as well as in medical students, and even nursing students, this is typically when you walk into pharmacology. And when I was taking it, the pharmacology was very difficult, or seemed to be more difficult. One of the things is that there are so many different drugs, several drugs you guys may not have heard of, or you may even have heard of. And, since it wasn't something specifically that you were, that you need to know, you may not have looked it up or meant to look it up. And But we've had, 10 cohorts that have gotten through, and we've seen the same thing. And again, one of the things that with this pharmacology, for the states that have applied for prescribing rights, one of the strengths has been, from what I understand, and I know I've written letters on two or three different for two or three different states just in the last couple of years. One of the things that I've got feedback for was the fact is that the program that you guys went through um, with regard to that, it takes away a lot of the sting from a standpoint of the physician saying, well, you guys are not trained, because you guys can hold your own. And one of the things is that that you will see is that and this gets to, Brady, your sort of your question there is, you will find when you get to the advanced courses where you're looking at the psych meds, because you are more familiar with them, that those will seem to be somewhat easier than these drugs that we actually have to have, that we have to cover with the curriculum. And the other thing is that one of the things that that you do see is we will emphasize, I mean, basically for pharmacology, as we go through these different drugs. So for example, last week, the last test that you guys had, are you all going to prescribe an anticholinergic drug? Probably not. Are you going to prescribe some of these drugs? No, but some of the drugs that you will prescribe will have anticholinergic or antiadrenergic type effects. And so that's important. The other thing is, by knowing, or at least being introduced to the drugs, we don't go down on the molecular level in this course like some of the pharmacology courses do. One of the things that I've seen, for example, with pharmacy students and even with the medical students, is that faculty like to go deep into the molecular mechanisms. And what happens is that students tend to lose the general mechanism because they're so caught up on whether it's a G protein or that sort of thing. But basically, as you start learning these drugs, you will see that there is some overlap, and you will see some common themes, and it'll become easier for you. And so I was, I took pharmacology. Let's see, my first pharmacology course was in '76 or something like that. So it's been a while, but I've, been teaching this for 30 something years. And, my pharmacy students this last, I'm not teaching the pharmacology to the pharmacy students the last couple of years, but their complaints were basically the same thing you guys had, that it was difficult. There was a lot of different drugs. And so that's an issue that comes up. But Kiara, when you ask about this, the board exam, from what I understand, when you're talking about board exam, the PEP exam, I'm assuming, that is written. And I do not know that, or have not heard in any hints of it being any oral exam or anything else like that. Now, I do know that Farley Dickinson did have an issue where that they were in students that did not do well in a course, that the students could quote remediate the course, and the remediation was basically very similar to the remediation did have an oral part onto it. The exams are multiple choice, and so the one thing that I will tell you guys some more about this, and I'm also checking to see. I'm going to check with Judy to find out if there's any plans for doing a PEP review, because we have done that in the past, sort of a separate. I used to do it in conjunction with Farley Dickinson. And Alliant and Farley Dickinson had a few of us that would do this, and I'll check to see if there's any plan, but that's a little bit in the future. The questions are multiple choice, and the best. And some questions, in fact, in the first few exams of the PEP exam, I understood that some of my questions were included. But the biggest thing is use the old adage. There's two things you need to do. One is when you're taking the exams, and this holds true for my exams too. Remember that the question is asking, and even though there may be a better answer, what you need to answer is, what is the best answer that's provided? Of the answers you're given, what is the best answer that's there? Some students on the PEP exams have sometimes learned, okay, so, the drug of choice is for ADHD, maybe Adderall. And Adderall wasn't one of the examples, and methylphenidate wasn't one of the examples. And so there were questions like that. I didn't write those questions, where that someone would be asking, really maybe a second or third tier answer. So the first thing I tell you is basically don't argue with the question, answer the first question, choose the best answer that's given. The second thing is when you are reading the questions and going through the answers, you're doing a rule out, you're doing a differential diagnosis. So use that to go through. And that's the important thing to do. And the other thing is, just like with the differential, one of the things that I tell people is you don't necessarily have to know the exact right answer, but by knowing what is not the right answer, a lot of times, we do this sometimes. We may not know a diagnosis, but what we do is we arrive at a diagnosis by eliminating the other alternatives. So that would be one of the things that we will try to, want you to do there. Okay. All right. So again, the answers to the questions should be made available to you after everybody's taken the test. But if you have a question, it's say you took the test and have a question about a specific one or two or three or four questions where you didn't quite understand it or wanted to know the rationale, then, please let me know. Now, there has been times when, the question has been keyed wrong. And so again, when somebody says, well, I didn't understand it, I look back at it, I may see it. So anyway, that just to tell you that. So this weekend, we're going to cover two groups of drugs. We're going to talk about cardiovascular drugs, and we're going to talk about pulmonary drugs, okay? The thing to think about as you were looking at this material, and again, what's in red is important. And so in general, for each drug, what we're going to have is a few prototype drugs, so examples that we will cover. But I'll cover some of the other examples so that you'll be familiar with some of the other drugs, because I'm not going to cover every beta blocker, for example, or I'm not going to cover every diuretic. So a couple of things that we want you to think about is for each drug, its mechanism of action, what's the side effects, and the other thing which, that I try to point out as we're going through the general pharmacology is these drugs that may have either symptoms that could mimic a disease state, for example, a drug that may cause depression. We'll talk about some of those today. And we'll also talk about instances where these drugs may particularly interact with the psychotropic meds that you might prescribe. So, but, some of these drugs we'll cover, which, 10 years ago, I would tell you when I covered the antihypertensive drugs, I would not have thought about prazosin, which is a drug we'll talk about today, would be used for any psychotropic type condition. And now we use prazosin for basically treating nightmares and some PTSD. So again, what we're going to do is we'll go through these drugs. I'll do a little bit of review, you'll see, with some of the pathophysiology so you can sort of understand how the drugs interact. But most of the things will be general mechanism of action, side effects, and in particular, any interactions either that can mimic a psychological disease or any condition that may potentially interact with the drugs that you might be prescribing, okay? So again, today we will start with basically we're looking at drugs that are used to treat cardiovascular conditions. And these cardiovascular conditions are going to help to be familiar with this, because many of you are going to have patients that are going to have cardiovascular disease as comorbidities. So therefore, you will see patients that are on medications. And sometimes a medication you might prescribe may be an issue because of that drug that you might prescribe or would plan to prescribe or want to prescribe may be producing, may have an interaction with drugs or may be producing some side effects. I'll point those out to you, okay? Let's see. As far as Gary, you asked about on the good books. On the first lecture, I mentioned a couple of textbooks. that could be used. There are some, as far as the PEP exam, there are some, I have not looked at those recently, but several people, there are examples of PEP. There are a few books out there that people have used to study. And I will try to remember to maybe get some of those, to get some titles for you guys, so that you can have it. But a lot of people, for example, in these courses, primarily studied my slides that I gave. When we've done PEP review, pretty much we've gone through highlights of my slides and other people's slides, and a lot of question and answer type things. So basically, what would happen is, actually, we had also generated a few practice exams that was done in the past. I don't even know if I have copies of those, but we'll talk to, I'll talk to Judy and find out if there's any plans for a PEP exam and a PEP exam review that would help you. So, Carolyn, you talking about the pharmacology text that we were talking about? Okay, yeah, I'll try to look those up today so that we can, to give you the examples of some text. I should have copies of them here at the house, but I'll try to get those and repeat those so if you have it. Okay? All right. Okay, so let's start with we're going to start and just go through these drugs sort of as we would do the disease state. So you should sort of follow them. So again, some of these drugs will be used to treat more than one disease symptoms. And if we can prescribe one drug that hits two or more disease systems, that's pretty good. Okay. So we're going to start with antihypertensive drugs. A lot of individuals, we have a lot of people with hypertension. Some basic things that we need to keep in mind, and this is important for you to know if you have hypertensive patients, even though you are not treating the hypertension, but you should know that, number one, we're dealing with a chronic disease. Number two is that what we're really doing is, in probably 99% of the patients, we are not curing the disease. We're basically controlling the symptoms, and we're doing that by primarily trying to lower the blood pressure pharmacologically. Now, so anytime we're treating a lifelong disease and we're dealing these chronic diseases, we always have issues of compliance. And this is particularly important with hypertensive patients, because one of the things that's happening is that they don't really have any observable disease symptoms. Okay. We call it hypertension the silent killer, because blood pressure goes up. And as I mentioned, I think last, when we talked about the pathophysiology, when blood pressure goes up, the most things that most people will experience may be occasionally some headaches or dizziness. And just think of all the things that can cause headaches or dizziness. These are all situations where that the individual, you know, if you think about it today, you could have a headache because I'm sitting here, everything's blooming here in Athens. It's partly cloudy, but you go outside and the pollen, people are getting sinus headaches because of the pollen. You've got people that can develop headaches because of, my wife and I ran some errands this morning, and she was sitting in the car, and I ran into one of the stores actually to get bird food for my feeders. And the guy sitting next to her, middle-aged guy, was talking on the phone and had his windows rolled up. My wife had our windows rolled up, but he was talking so loudly that, for the 5 or 6 minutes that I was in there, she ended up having a headache just simply from that. So there's sinus headaches. There may be, all sorts of different reasons people get headaches, stress, so forth. So a lot of people, when they start seeing headaches, they basically are, they're going to, just assume that it is due to something else, not that their blood pressure's up. And people that know they have high blood pressure, a lot of times they may recognize that when they get a headache, that it's due to their blood pressures coming up. So we have a we have a disease that has very noticeable symptoms. In fact, when we start seeing noticeable symptoms, usually secondary to damage to end organs, then one of the things that we're probably seeing is that there has been already some significant irreversible target organ damage. But one of the things that may be helpful when you guys take vitals and the individual's blood pressure is up, one of the things that you can, encourage them is to make sure they're taking their medication. But we have something that is no readily observable disease symptoms. We have lifelong treatment. Pretty much we're not curing it. And it's important that they take their medication because without taking their medication, the bottom line is going to be they are going to, the hypertension is going to progress. And as it progresses, it's going to cause more damage. So when a physician chooses a drug therapy for this, they have to take it. And this is the same three things that you need to be considering. Is when you're selecting therapy, you need to consider, will the patient take it? If not, is there a better drug that may improve compliance? So for example, in general, if someone has to take a drug 3 or 4 times a day, compliance tends to be worse than if it's once a day. So in some instances, when you choose a drug in general, it may be you choose an extended release or one with a longer half-life so that to help with compliance. Some people once a day can be forgetful. I mean, they forget it. And so one of the things that we may do in those individuals sometimes is having them take it multiple times a day. For some reason may actually work a little better. What side effects? All drugs have a potential for side effects. So what we need to do is we need to primarily think about, if let the patient know that if there's any side effects, let us know. And once we know what the side effects are, we can maybe do things to reduce those side effects. Maybe change the drug. Maybe look to see if there's a drug interaction or a food interaction. And then, of course, economics. Can the patient afford it? And again, as I've said before, one of the things that we need as far as economics is many drugs now are generic and so have gotten cheaper. But on the other hand, sometimes even with generic drugs, it's a question of whether the patient can afford it. We do see individuals that cannot afford even generic drugs. We are going to take advantage of non-pharmacological behavior, and we do this when we can with almost any disease state. The problem with these non-pharmacological therapy is that if the blood pressure's elevated a little bit, not a whole lot, we may see if we can handle it by non-pharmacological methods. And that works sometimes, some patients, but that does require behavioral changes, and that may be more difficult for some patients over other. Even if the patient follows it and is being compliant with non-pharmacological changes, what we have seen is that some of these patients still, it may not lower their blood pressure low enough. And so what we typically say is when we're treating patients for hypertension and we're using these non-pharmacological therapies alone, what we typically say is let's give them 3 to 6 months at max. If the blood pressure does not go down to an acceptable level, then we're going to probably use medication. But we have found by using non-pharmacological method and the medication, many times we can use lower dosages and we have less side effects. And the non-pharmacological therapy include, most of you could probably give these to me on top of you. One is we're going to restrict sodium, okay? Now, one of the things, and I think I mentioned it to you, but if I didn't, when we take our break, if you're at your house or you're, maybe at your office, whenever, take a look at especially at your house. Next time you look at the cabinet, pick up the cabinet and, open up the cabinet and pull out stuff and read the label. And if you see sodium anything listed in the first 5 ingredients, there's a pretty significant amount of sodium in that product. So we see a lot of sodium coming from the diet, canned foods, pre-processed foods. One of the things that we've seen is a lot of fat-free diets. There's decreased fat, but there actually may be increased sodium. And we all know with fast foods, one of the biggest things is fast foods are successful because they're fried, they have high fat, high sugar, high salt. Those 3 things in particular, the high fat, high salt, and high sugar, are very palatable to a lot of people. And so that's a big issue that we see a lot of people that, because of their schedules, start eating a lot of high sodium foods. We want to have them lose weight if we can, because weight does add, we do have people that are heavy and have normal blood pressures, but exercise also works. Exercise will help with the weight reduction, but also exercise reduces stress. And we also see with a lot of psychotropic drugs that exercise can be very beneficial if we can get people to do that. And then we look at other risk factors that can affect the vascular system. We want to lower their cholesterol. We want to see if they can reduce their cigarette, tobacco use. One of the big things, I don't know if you guys have seen it, you probably have, but there's a lot of concerns with vaping. I just, basically talked to a student this week who switched to vaping as an alternative to cigarettes, and I gave him a bunch of articles. There's a lot of articles coming out now where there's concerns about vaping, and one of the things that we're seeing with a lot of places is people are vaping and they may be swapping nicotine for cannabidiol or CBD oil or other things. Alcohol, typically we do get an assessment of their alcohol use, and we generally want individuals to reduce their alcohol consumption, even if they're not heavy drinkers or moderate drinkers. That a lot of times can help. So let's look at the first big group of drugs that people use, and these we're going to start with the diuretics, okay? And diuretics, we have what are called, we have several classes, and they each have some significant benefits, and sometimes, the pros and cons are there for a lot of them. So one of the things that we see is the weakest diuretic that we have are what we refer to as the thiazides, okay? The nice thing about them, a lot of them are easy to recognize because the end of the word says thiazide. But probably the two very common ones that we use is hydrochlorothiazide, and we have chlorothiazide. Hydrochlorothiazide a lot of times will be abbreviated HTZ in the charts. Just put that here. So that's a very common diuretic there. But many of these thiazide diuretics are available, and most of them, if not all of them, I think are now generic. So they're cheap and readily available. And the thiazides, and we do have some that are thiazide-like, which primarily have thiazide actions, but so we sort of include them in that. But let me just give you the breakdown to get a breakdown with regard to the different categories of diuretics. So we have, let's go back one here. So we have the thiazides. These are usually the low potency ones, the ones we typically start off with. Then we have what is called the loop diuretics, and the prototype we're going to use here is furosemide, also known as Lasix. These are the very, very powerful diuretics. And these very powerful diuretics are, they can produce very heavy diuresis. We may see significant amount of water loss with these particular diuretics. Then we have what is known as the potassium-sparing diuretics. One of the problems we have with many of the diuretics is we can lose sodium and potassium. We really want to lose the sodium, but we don't necessarily want to lose the potassium. And so these potassium-sparing diuretics basically will produce a diuresis, but they do so without as much potassium loss. Now, I will tell you that these diuretics typically are not going to produce a strong diuresis. Sometimes we may have to use another diuretic with it, with a lower dose. But we're going to pick two to look at, and one is called amiloride. The other is called spironolactone. The reason I'm giving you two in this category is because there is a difference. Amiloride basically is acting through one mechanism. Spironolactone acts through a different mechanism and has some unique properties. So we have three major categories. We have the thiazides, we have the loop, and we have the potassium sparing. Okay, if you were to sort of separate out what the big difference is, the thiazides are the low potency ones. We see these used a lot. Basically, what we're dealing with is you get a persistent diuresis, whereas a loop diuretic is a very powerful diuretic. And so we will get very prominent and a very strong diuresis. And then we have the third type, which is the potassium sparing, which still produce a diuresis, nowhere as strong as with the loop diuretics. But the big advantage to them is whereas the loop or the thiazides will produce more potassium loss, these potassium sparing diuretics don't do that. Okay. So the mechanism of action of all three classes are very similar as far as their therapeutic component. And basically what we're doing is this, is that we are really just trying to get a persistent, moderate diuresis. Okay, so what we're basically doing is that we are, by causing urination, the diuresis, the idea is that we're going to reduce the extracellular fluid in the body, and we're going to and eventually reduce the plasma volume. So by reducing the water load, sodium and water load, what that's going to do is that lowers our blood pressure. And in fact, we do know that the initial drop in blood pressure is because when we get rid of that extracellular fluid and plasma volume, the cardiac output goes down because it's not pushing as much volume in there. And then over long term, what happens is that the body sort of adapts to this lower reduction in our peripheral resistance. The force of the blood vessels that are resisting the flow, which is an index of our blood pressure, actually goes down. So we initially get a lowering of blood pressure because our volume goes down, and then our body adapts to the lower volume, and our blood vessels actually sort of have less resistance. So that's why blood pressure goes down. So this mechanism of action is pretty much, if you sum it up, is what we're doing is by lowering the amount of fluid in our body, then the heart and the blood vessels don't have as much pressure. Okay, so this occurs for all three types of general mechanism occurs for all three categories of diuretics. Now, one of the things that we see is let's see, for some reason, okay. So my slide was not being advanced by the hot button there. Okay, so the advantage of these diuretics are, one is they work. That's a simple mechanism with regard to that, is they do work. Angela, the transgender patient that you're on does produce that. We're going to talk about that. That's one of the reasons I gave you guys spironolactone, is because it has a unique little characteristic there that deals with a hormonal value. So we're going to talk about that in just a little bit. So what these diuretics do in general, when we're talking about lowering blood pressure, so one of the things that's happening is that these drugs work, and what happens is that they work in a large number of patients. Sometimes that's the only drug we have to use. When I say monotherapy, means sometimes we can give someone, typically it's somebody that's a stage 1 hypertensive, their blood pressure is not really elevated very much, but we can give them a diuretic, and basically that, a thiazide, and that works great. But in many patients, the thiazide will help, or the diuretic will help, but we need to go to some additional, and so we can use it in combination therapy. The other thing that's nice is in combination therapy is that some of these other drugs, by lowering blood pressure, they decrease renal blood flow. And when they decrease renal blood flow, one of the things that can happen is you can accumulate fluid. So some of these drugs, by lowering blood pressure, may actually produce some accumulation in edema. And so if we have a diuretic there, that helps get rid of the edema. So by using a diuretic, sometimes it will offset some of the side effects of another drug that we may be using. Another big thing is almost all of these are generic. So these are pretty cheap. That is especially helpful in a large number of these populations that we're treating, but especially even the elderly and the lower income classes. Many of these diuretics, even if they don't have insurance, are very, very inexpensive. The other big thing is, from a side effect profile, these drugs basically work pretty good. They have very few side effects. That's an important thing here, is that most of these side effects, which I'm going to talk to you in just a moment about, are minimal and manageable, okay? Now, the other thing that comes into play is diuretics have been around for a long time. So the medical community has an enormous amount of experience with these diuretics. They've got a good knowledge base. And so that's another thing that contributes a lot to safety, is that we've had a lot of people on these diuretics over the years. And as a result, we're very comfortable with these individuals, and that works pretty well. Now, let's look at the disadvantages, which really comes into the side effects, okay? For all of the diuretics, there's one side effect that is pretty common that we typically have to be aware of, and that we have to be careful of. It's not overly an issue, but we know it occurs in most individuals, and it can create some problems. Many people adapt to it. So for all of the diuretics, regardless if it is, the thiazides, the loop, or the potassium sparing, we can get electrolyte imbalances. In particular, we worry about sodium. Okay, so sodium, basically, what we're doing is the diuretics are acting on the tubule, whether it's the thiazides act on the proximal tubule, the loop act on the loop of Henle. The potassium sparing ones act on another area, but they're all acting on the kidneys. And what's going to happen is that we're going to, when we lose water, we lose sodium. And many times we're going to lose the other electrolytes. So we lose potassium, we lose sodium, we lose calcium, we lose chloride. So any electrolyte can go down. The potassium sparing ones, we don't lose as much potassium, but we still lose sodium, and we still lose several of the others. So with these electrolyte imbalances, typically most patients, this is going to be expressed in, how would you expect these, what symptom would these individuals have by losing electrolytes? Can you think of anything that would particularly occur? Okay, so one thing may be syncope. That's not so much the electrolytes, but it is there. So syncope, dizziness, being tired, lightheaded, something else. Heart problems, if you get too much diuresis. So I would agree that faintness, we always have to worry about when you drop somebody's blood pressure. They could be that. One other thing. What happens when you, if you're active and you sweat out a lot of electrolytes? Right. So one of the things that we see, these electrolyte imbalances, we really see a couple of things. We see muscle cramping, and one of the things that sometimes patients, when we first start them on there, we may tell them they may get some muscle cramping, and that is because their body's sort of adapting to it. But the other thing is, like you guys said, we can see some lightheadedness or dizziness, and in some cases even syncope. So that's one of that's probably true for all of those. The loop diuretics it's a big concern with the syncope and so forth. Now, some other things that can occur, serum lipids with some of these diuretics will go up. So if somebody has a high cholesterol, we may question as to whether we want to, basically, we may need to monitor that patient's lipids. Metabolic alkalosis, that can be due to too much loss of electrolytes. That's usually with the loop diuretics, but people on higher dosages. It can affect many of these can affect carbohydrate metabolism. We might want to be a little concerned with diabetics on that one. But one of the things that we see is hyperuricemia. That's gout. So what happens is when we sort of dilute things out, uric acid crystals can sort of precipitate. So this is a problem, particularly with some of the thiazides, we may get some gout that's occurring. And as I've said, these drugs do work. They can be used to minimize the side effects of other agents. Other antihypertensive agents may actually, by lowering blood pressure, you decrease the kidney perfusion pressure. And that is why that sometimes people will develop edema or peripheral edema with blood pressure lowering agents. And if that's the case, what we're going to do, the diuretic will often help. It'll get rid of that edema. Typically, just like with any other drug, we try to use the lowest effective dose. We do see with many of these diuretics that it sort of has what we call a flat dose. And so these work over a relatively narrow dosage range. And sometimes when we get to the diuresis, we get as much as we're going to get. If we simply keep increasing the dose, then pretty much all we get is side effects. So we do recognize that the dosages that are recommended typically work pretty well. But when we start going out of those dosages, a lot of times we don't really get any benefit. We call that dose response being flat, because what's happening is with the dosages that we've used, we've pretty much maxed out the system. Typically what we're going to do with a lot of one of the big concerns we have with a lot of therapy is people get impatient. You guys, the drugs that you are going to prescribe, you realize that, for example, antidepressants, that you're probably looking at, 1 to 3 weeks before you see an effect. And you may be looking at 4 to 6 weeks before you see, really what effects you're going to have with that dosage. So typically what we're going to do is we're going to put them on the drug and keep them on the drug for a couple of weeks and say, let's see how you do. Probably after those 2 weeks, we're going to bring them back in, have their blood pressure measured, or we may send them somewhere to have their blood pressure measured. By the way, one of the places, like my mom, her doctor sends her up to the fire. She, instead of having to come in the doctor's office, she can go up to the fire department, and the EMS people will do that. So we don't want to, what happens if we try to dose too quickly? A lot of times we get more side effects than benefits. Now, here's something you guys need to be aware of. So typically we want to dose once a day, and we prefer to dose early in the morning. Now, an interesting thing came up the other day with one of my students, because we had told them to dose once a day, especially early in the morning. Well, the student had recommended that, and it wasn't working out. And the reason it wasn't working out was because most patients we think work on day shift, and his patient that he was working with basically worked on night shift. So the point would be is that when he dosed him early in the morning, so for example, when he came home from work, one of the problems was he had problems sleeping because he was getting up during his day shift job or during his resting time, which was during the day, going to the bathroom. So one of the things that we have to be careful about is that we need to tell these individuals that you're going to have increased urination. A lot of times we talk to these patients and we inform them that this is a water pill, is the way we describe it to them. And so one of the things that can occur is that these patients may show up to you and may tell you that you're not prescribing their antihypertensive drugs, but they may start telling you, they've been to their doctor, he's put them on a diuretic, and they go, they come into you and you say, how you feeling? And they're going, I'm not really feeling good. I'm not sleeping well. I just can't stay asleep. I'm getting up a lot at night. Can't get back to sleep. So one of the things may simply be is that they may be taking, we have had patients that we tell them to take the drug in the morning, and they don't want to take it in the morning because at their place of work, they don't want to go to the bathroom at where they work. They don't want other people knowing when they go to the bathroom, or maybe they don't like the bathroom that they have to use for whatever reason. They don't think they have privacy, or they may be concerned about, catching something in a public toilet, those type of things. And so sometimes we've had people come in saying they can't sleep at night. People don't know they're on the diuretic. And so one of the things that happens is that they're taking the diuretic late at night and they're getting up and going to the bathroom. And as a result of that, they want something to help them sleep. Well, let's say you prescribed Ambien for them. The downside to that is they may sleep, but they may wet their bed. But sometimes fatigue and insomnia may be related to drugs that may produce nocturia. So just keep that in mind. We see other uses for them in general, to decrease intracranial pressure, to reduce intraocular pressure, which would be with somebody with glaucoma. But typically and we also see them in addition to lowering blood pressure, we see them to treat pulmonary edema, and even edema in general, peripheral edema, where you get fluid around the ankles in particular, or in the lower legs. That can be very uncomfortable and painful. Pulmonary edema makes it very difficult for them to breathe. We see that a lot of times in heart failure. And we do see these diuretics used to treat congestive heart failure. Particularly what we're doing is treating the congestion part, which many times we won't use a thiazide. We would typically be using something that is like Lasix or the furosemide. So the things that you need to be aware about if you with diuretics, and I'm going to bring up another thing in just a minute, may hit you guys directly. So number one is loss of electrolytes is going to occur. That's the most common side effect that we see. That is typically expressed as people being dizzy, cramping. These are the two biggest reasons that my mouse is not cooperating today. Here it is. Two biggest reasons that we see is that basically is dizziness and cramping, and this is due to the electrolyte loss. But the other thing is it's linked into here is the postural hypotension. Okay, postural or orthostatic hypotension is where the blood is having to, because you get any drug that lowers blood pressure, makes it more difficult for the body to adapt to changes in posture. So a lot of times we tell people when we start them off on the drug, or we basically make a recommendation for them to increase a dosage, what we typically are going to tell them to do is just take a few minutes to when you get up. So, if you're sitting down, take a moment when you stand just to make sure you're not dizzy. You're laying flat, which is more of an issue. You're, getting up in the morning, first thing is sit up on the edge of the bed. So you're sitting up, take a moment or so. So that's what we try to tell them. Normally they will adapt pretty well. And many of these effects usually diminish within about a week, 2 weeks maximum. But a lot of times after 3 or 4 days, that's fine. The elderly in particular is a concern. Okay. The elderly are more susceptible to postural hypotension. The other thing the elderly are, they're susceptible to falls. So any drug that lowers blood pressure, the elderly, we have to be careful about. And especially if they're having nocturia, an older person gets up late at night and is trying to go to the bathroom, they're more prone to fall. They're waking up. They may not be asleep. Lights are off. They may not see things. So we're concerned about that. But most of these effects, even the elderly, tend to diminish. They may not always go completely away, but they're usually manageable. Probably one of the biggest things that you need to be aware of is this last point right here. You guys will be prescribing lithium. All right. Lithium is sort of a unique drug in the sense that it does not undergo liver metabolism, okay? Lithium is excreted completely through the kidneys. And so what happens with lithium is that when you have a diuretic, the diuretic is pushing sodium and water out. And lithium, in the influence of a diuretic, the lithium doesn't get pushed out because it's going through the same pathways that the sodium is going. So if we're excreting sodium, then the chances of us excreting lithium go down because the sodium and lithium are competing. And so one of the concerns with diuretics, I usually get called about, well, it was, probably about 2 to 3 years ago. I typically would have calls from lawyers where that someone had experienced lithium toxicity and was because they were given a diuretic. And I would typically get 3 to 6 phone calls a year with cases where they were suing the doctor for prescribing a diuretic or suing the psychiatrist for not being, or the pharmacist for not being aware that there's an interaction. So with lithium, I say use caution with lithium because to me, caution would mean if I can use another drug, I'm going to do it. But if there is a reason that you feel in that particular patient that you need to use both, one of the problems you need to do is you need to monitor lithium levels because what you're going to see is in the presence of a diuretic, you can get lithium toxicity. Okay, so that's a key point. When somebody's on a diuretic, be extremely aware of the potential for lithium toxicity. If someone is in kidney failure, thiazides in particular, they tend to reduce glomerular filtration, so we don't like to use those drugs if somebody's got some kidney failure. Can be done, but again, we got to watch it. Mentioned about hyperuricemia, so that by dropping the blood volume down, you basically concentrate the gout, and the uric acid concentrates and creates this gout. And we have to be careful in diabetics. We can get some hyperglycemia. So careful with that. Although these drugs are fairly safe, we have to be careful in renal failure, with gout, and with hyperglycemia. You know, it's interesting, when I was coming through pharmacology, I never heard of anybody, I mean, gout was sort of like, you didn't hear too much of it. And now I see it a lot of times, and a lot of times it's due to people's diet and so forth. I see a lot of people that have very, very difficult times with gout because it is, it basically affects their quality of life. There's a lot of pain there. Okay. Now, let's go to this issue that came up with potassium-sparing diuretics, okay? So let's see, who was it? Angela had mentioned that she had a patient that was a transgender client, was put on it for hormone therapy. So let's take a look at that. So its potassium-sparing effects is because it blocks aldosterone. It's an aldosterone antagonist. So that's an important thing here, is this is the diuresis component, okay? But look at this structure. This is known as aldactone, which is spironolactone. That structure is very similar to steroids. It's got a steroid backbone, okay? So this is an example where that the structure suggests that. So what we actually see is that spironolactone, in addition to being an aldosterone antagonist, also is a weak progesterone because of its structure. It's very similar to progesterone. And so, Angela, that is where the hormonal therapy is coming in, is they were using the spironolactone for its progesterone activity there. Now, we also see, with regard to this weak progesterone, that in males, that it has been shown to produce gynecomastia. And that may or may not be reversible. So reversible, if we stop the drug, it goes away. If we stop the drug and it doesn't go away, that's considered irreversible. If it has to be treated, then they usually do it surgically. Interestingly, we used to see a lot of people that were on congestive heart failure. This was a drug that was used because we didn't want them to lose too much potassium. And one of the things that many of the men complained of was, many of them complained of breast growth or gynecomastia, and they also complained of the breast pain. Their breast was tender. Some of them said they had difficulty sleeping at night, that if they rolled over on their, lay on their stomach, that their breast hurt them. And that was due to this progesterone effect that we had. Now, like I've said before, side effects, one of the things can be extensions of the pharmacology. And here's a good example. So it retains potassium. So one of the big things that can happen is basically we could get hyperkalemia. And remember about potassium is potassium, low potassium or high potassium, is very important, can produce very significant effects. Either one of them can produce serious arrhythmias. Okay? So, Angela, the reason that is there, a reason you're seeing it in the transgender patient, is they're using it for this weak progesterone type activity. And the other one we have, so spironolactone acts as sort of an indirect, and it is affecting the aldosterone. And on the other hand, this other drug, amiloride or triamterene, that doesn't interact with aldosterone, okay? So it's regardless of the aldosterone status, it will work. And it tends to be more reliable than spironolactone. Still, the problem, because spironolactone is doing it indirectly, where this drug is actually doing it directly. It still has a potential for producing hyperkalemia because it is a potassium-sparing drug. So that is still the same thing that we have to worry about. Again, both of them, spironolactone and the direct-acting agents, are both potassium sparing. They're acting on to retain potassium. We still get sodium reduction, but we don't get as much potassium reduction. So let's cover the loop diuretics, and that will finish the diuretics, and then we'll take our first break for this morning. So the loop diuretics, as I've said before, they're the most powerful because the most concentrating portion of the kidney, where we really control the ability to concentrate or dilute, is in the loop of Henle. So you have to think back there. So by acting on the loop of Henle, we're acting on the most sensitive part of the kidney. So we can have great changes in volume, and that can be a big issue there. So this is a very potent drug. The loop diuretics are very, very potent. We don't want to use them we want to use them when we have to get rid of a lot of fluid. That's the important thing. They produce, they can actually, you can lose liters of fluid in a short period of time. And one of the things with these loop diuretics is they've become very popular to be abused. That's why I've got the little NFL thing down there, is that people have used these to drop weight. And so we've seen sports, athletes use it to try to drop weight. Weightlifter, or I should say bodybuilders, like to use these drugs. And what it does is it sort of dries them out so that their muscle definition is more prominent. We also see this used in people with sometimes eating disorders. And not only loop diuretics, we see the thiazides too. We see a lot of young girls that will use diuretics, and they will buy also substances off the internet, which are supposedly have some diuretic properties, again, to lose weight, to get rid of that water weight. And this time of year, we tend to see it because people is getting, summertime, people are going to the pools, people are going to the beach. And so the idea is that if they can drop 5 or 10 pounds pretty quickly, these are abused because what people get into the use of doing it is some of them will push the dose because the idea will be, well, I lost 10 pounds by doing this one, so if I double the dose, I'll lose 20 pounds. So that is sometimes the issue. There was what's the name of it? I think there was a magazine that was out several years ago called Muscle and Fitness, and it may still be out there, I don't know. But one of the bodybuilders wrote a sort of a story about he was using Lasix. He was using steroids and he was using Lasix. And the idea of the steroids would build up his muscle. He was working out, and then he would use the diuretics like 1 to 2 weeks prior to competition to sort of get him really dried out so he had real good muscle definition. And they showed a picture of him. Actually, they were carrying him off the stage, and he looked almost like a statue. He described it as almost like his whole body cramped up, and he had severe depletion of electrolytes, and they carried him straight to the hospital. He almost died. But after living, he came back and was writing about how misuse of this is pretty rampant in athletics. Football players and basketball players, in particular football, may use it to try to drop weight, try to get a little faster. So, and we do see it in people that have eating disorders. I don't know if any of you guys have had an issue with regard to any of your patients that have eating disorders where they're using these diuretics, but in fact, that's in fact a potential there. Yeah. All right. So we've covered through diuretics. This is the first group of drugs that we'll cover. What we're going to do is we're going to start talking about one of the big things with these diuretics is, again, from your standpoint, people with eating disorders or body dysmorphia may be using these to lose weight. They're generally safe drugs, but the biggest thing is going to be excessive, pretty much our biggest concern is going to be excessive loss of electrolytes. The other thing that could happen is we could just drop blood pressure in some individuals too low. And the one drug you want to make sure you're careful with that you would prescribe is going to be lithium, because that can definitely elevate the lithium concentrations if you're using it. More of a concern with loop diuretics and than with the thiazides, but on the other hand, it can occur with the thiazides. And on the potassium sparing drugs, the biggest concern we typically have, of course, with spironolactone, we have the steroid component. So we may get gynecomastia and some progesterone type effects. On both classes, whether it's the direct or indirect acting potassium, is one of the concerns is that we get too much potassium sparing, where that we actually develop hyperkalemia, which could produce life-threatening arrhythmias. Okay. All right. Let's take our break and let's come back at 1:20. Or I'm sorry, 20 minutes after. That'll give you just a little over 15 minutes for a break, and then we're going to pick up and start talking about the central nervous system acting drugs. And Marissa, I sent you. Did you get the questions I sent last night? Okay. So you can, what we'll do is we'll do the first 4 questions at the end of this morning session. So when we finish up around, 20 to 30 minutes before the hour, and then we will do the next set of questions this evening, the last, and I will send you Sunday's questions and the post test later on today or this evening. Okay. So we'll come back and I'll see you guys at 20 after the hour. Okay, guys, we're ready to go back again. Does anybody have any question about the diuretics before we move on? All right, so let's move on to the next group. Now, this next group of drugs, there's a couple of things that just to be aware of is these are the drugs that actually are going to lower blood pressure by working in the central nervous system. The interesting thing, one of the interesting things about these drugs was that when it's like in the 1950s, I think it was. Prior to the 1950s, we didn't even think that blood pressure was regulated through the central nervous system. And actually, some of the work with methyl-dopa was what actually opened up opened up our eyes with regard to that there were areas in the brain that actually control blood pressure. So these drugs came out. And of course, you probably are familiar with clonidine because we've seen a few uses of clonidine in like ADHD, and we're seeing clonidine being used in some addiction medicine for that. But all of these drugs that came out, to begin with, it was methyl-dopa and clonidine were the two centrally acting drugs. And then we've added a couple of others that are these guanabens and guanfacine. These are very similar to clonidine in their actions, and I'll just sort of make that as oops, hit the wrong button there. So what we see is that this clonidine, which is acting primarily on alpha-2 receptors, is these two drugs are very similar to that, to clonidine, okay? Now, the other thing is that we talked about, we mentioned them last time we met, beta-blocking drugs. We talked about beta agonists, but I just mentioned the beta blocking drugs because we're really going to cover them today. But a lot of these beta blocking drugs also have prominent CNS actions. They will produce some of their effects. And in fact, some of the reasons that you might be using beta blockers and you might potentially prescribe beta blockers is due to their central nervous system actions. So just to keep that in mind. But, excuse me. So let's go through methyl-dopa. Now, methyl-dopa has an interesting mechanism of action. So the first thing is methyl-dopa actually has to be taken up into the neuron. That's a key point. So we're actually looking at methyl-dopa as being sort of a prodrug in a way that, so it has to be taken up into the presynaptic neuron, and it actually plugs in to the catecholamine synthesis mechanism. So what happens is methyl-dopa is actually converted to methylnorepinephrine. And then some people describe this as a false transmitter because the methylnorepinephrine is released when the neuron fires. And so instead of norepinephrine being released, or in addition to norepinephrine being released, what's literally going to happen is it's going to release norepinephrine and methylnorepinephrine. And it appears that the methylnorepinephrine, it has more of a affinity for the alpha-2 receptors in the brain. And so this drug is basically going to stimulate the alpha-2 receptors in the brain. And when you stimulate alpha-2 receptors in the brain, so these central alpha-2 receptors will actually lead to a decrease in sympathetic nervous system outflow. So what that means is that the sympathetic nerves going to the heart and to the blood vessels basically are going to fire less. And with them firing less, there's less stimulation of the heart and the blood vessels. And so as a result of that, blood pressure goes down. But notice down here, I've got the structures here. So here's dopamine, and here's levodopa. And if you notice that with regard to compare levodopa to methyl-dopa, notice right up here is that we have, here we have a hydrogen group, and then we have a methyl group here. So that's where the methyl-dopa comes. And basically what's going to happen is, remember the synthesis of catecholamines, you start off with L-dopa. I mean, basically we go we go from L-dopa to dopamine to norepinephrine. So when this comes in, we get methyl-dopa going in to methyl-dopamine to methylnorepinephrine. So it uses the same synthesizing enzymes, plugs right into that cascade. And again, what happens is the neuron makes more methylnorepinephrine. So and less norepinephrine. So when methylnorepinephrine is released or when the neuron fires, basically what's going to happen is that we're going to get more methylnorepinephrine released, which is going to be more potent than norepinephrine. So we get a greater effect. So it's sometimes referred to as a prodrug or a false transmitter because the methylnorepinephrine that is being released is not the natural transmitter, but is instead a secondary one. So these centrally acting drugs are going to have some very similar actions up in the brain. One of the things that we saw in the 60s and 70s and actually probably 60s through the 90s, we saw a lot of centrally acting drugs being used to lower blood pressure. The problem with these drugs is the side effect profile was problematic. It was problematic in the sense that many of the side effects were very unpleasant. What we typically saw was one big thing was sexual dysfunction. Now, individuals with high blood pressure can develop a sexual dysfunction, but these drugs in particular became a problem because they were effective, which is why we used them. But the side effect profile, here you have, let's say, a late 20, 30-year-old male, has no symptoms. His doctor diagnoses him with high blood pressure, puts him on methyl-dopa, and one of the things that starts happening is he gets sexual dysfunction, get erectile dysfunction, impotency. And so that results in he's now I'm not feeling any, I don't have any side effects. Excuse me, I don't have any pathological effects. I'm not feeling anything because of my high blood pressure. Now you're telling me I have to take this drug, which basically makes me impotent and have erectile dysfunction, and I'm going to have to take it for the rest of life. So I'm basically paid for these side effects. So we had a lot of compliance problems with that. Another thing we saw was, and this is true for most of the antihypertensive drugs, is orthostatic hypotension. You lower blood pressure, it takes a little bit more for your body to do, to have to deal with more stuff. So therefore, you just have to tell people that they have to take more time to, stand up and take a little bit more time like that. Another common thing we saw is somnolence. They were sleepy. They didn't have any energy. And that was especially in the first few weeks of starting therapy. Again, what we had to do is we had to try to talk them into, keep taking the drug. The things will get better. Now, the somnolence usually improved. The sexual dysfunction usually did not improve. But a big concern here that we saw with these drugs is right here, and that's what affects you, is that we saw that depression, if it could be unmasked. So if they already had depression, then the issue may be is that it got worse, or so it could either unmask it or exacerbate it. So one of the things is that, back in the 50s and 60s, and so maybe even 70s, the thing is that the way that a lot of people didn't even put this as an issue with regard to the hypertension. They might say, oh, the person's depressed because they found out they have, high blood pressure and they're having to treat it. But we've come now to recognize that this is an important component and really makes an issue of, especially with other drugs that we have, it makes it really a concern as to whether we really need to use methyl-dopa if someone has either the potential for depression or has depression. So what we saw very commonly with these CNS-side drugs, and you'll see it's very similar with clonidine, is sexual dysfunction, orthostatic hypotension, somnolence, and potential for depression. So that was some major concerns. And right now is, from a pharmacological standpoint, if someone had depression, I would not recommend them being on methyl-dopa. If they are, and for a good reason, we did have some people saying, well, that it's really controlling their blood pressure and they're tolerating it. And if depression occurs, I think that I'm not sure I'm going to take them off of the drug. But on the other hand, since it's being controlled pretty well, but I'm going to watch them very carefully. Now, some drug interactions we did see. Think about these drugs, these CNS acting drugs. typically are considered CNS type depressants. And Jason, from a standpoint, I don't think anybody ever looked at that. I don't think that there was ever a link that was associated with it. A lot of people, one of the things that happens with these older drugs is that we saw a lot of side effects that occurred. They were the best drugs that we had, and people were recognizing the major concerns with that. And so as a result of it, some of these things that we saw, I mean, pretty much it was like, well, we saw a lot of people in the 60s, 70s, 80s, and 90s, actually until the ACE inhibitors came out, is pretty much they were on a diuretic, potentially a CNS acting drug or beta blocker, and maybe even another drug. So 3 drugs, and the side effect profiles were very similar. So as these drugs got replaced, no one has gone back to try to make a case for, the other thing is these drugs have gotten older. And so generic drug companies are not going to follow them or try to test them. And the name brand companies are not going to try to get another indication. They would not have a patent for it. So these are some things is that where an issue. And there may be some studies out there looking at increased REM. I'm not sure, but there's a possibility, but I know the drug companies didn't really push it. So we have seen some increase in lithium toxicity. Not really sure exactly. One thing that could occur is methyl-dopa could affect renal blood flow, which may decrease lithium excretion. The other thing is with the lithium, you might see that the issue becomes that the CNS depressant actions may be combined there. Levodopa, L-dopa in people that were with Parkinson's, one of the concerns we saw was that we may get excessive hypotension, because basically with the L-dopa, it goes across the blood-brain barrier. It can drop blood pressure. And propranolol, we do see there is a paradoxical hypertension, so that propranolol may be blocking some of the actions. There's some effects that propranolol have on the neuron, which we'll talk about in a little bit, that could potentially prevent the uptake of methyl-dopa. And the other things we saw with sympathomimetics, we seem to get hypertension. Notice I really didn't put any of these in red because they really are sort of minor observational type things that have occurred, and we've seen a great reduction in methyl-dopa use. Now, clonidine is going to be a direct acting agent. Clonidine we still see used quite a bit. Again, not so much for controlling blood pressure, but for other indications. And clonidine does not have to be converted to a false transmitter. Clonidine stimulates the alpha-2 receptor. It binds directly to the alpha-2 receptor. So it is a direct agonist, if you would. And so it's going to stimulate the alpha-2 receptor, binds directly to the alpha-2 receptor, and it's going to cause a decrease in sympathetic outflow. When you take clonidine, clonidine has a little bit of alpha-1 receptor activity. And so if someone was to take a large dose of clonidine orally, sometimes what we can see is blood pressure initially goes up and then drops down. And that increase in blood pressure is due to stimulation of the alpha-1 receptors in the periphery on the blood vessels to cause them to constrict. But then when it gets into the brain, basically what's going to happen is that the clonidine is going to stimulate the alpha-2 receptors, which is going to decrease sympathetic activity. Side effects, some very common things that we saw with methyl-dopa that we also see is we see sedation, that's somnolence. We see that. We see the sexual dysfunction. We actually see the orthostatic hypotension. We do see some dizziness and dry mouth that can occur. Some people have complained of constipation. But again, most of the CNS acting drugs, we're going to see somnolence. We're going to see sexual dysfunction. And we also will see, looking at the next slide real quick, and then I'm going to come back in just a minute. So we see this depression here. We have seen some insomnia that has occurred. People have, even though we get somnolence and sleepiness in some individuals, we do see some insomnia. Some people have argued that what may be happening with the insomnia is that people are napping during the day and can't get, so they take a bunch of quick little naps and they may not be able to have a long, more full sleep or rest. So that's an issue. We have seen some agitation and anxiety. So one of the things with clonidine, we don't see this. I mean, I think there are some reports with methyl-dopa, but it's more prominent with the clonidine. And the thing about it is this is one of the things. The depression is a big concern that you should have, but also if you see some of these other things in a patient's on clonidine, especially just starting the medication with a dosage escalation, that would be concerns that it could be clonidine induced. And then going back to the previous slide, just wanted to point out one other thing is we do have a patch for clonidine. It's one of the few antihypertensive drugs that there is a patch. And what we've seen with the patch is not unique to clonidine. A lot of individuals that have fair complexions, we tend to see some local reactions around the patch, irritation, skin reactions that occur. We've seen it in women and in patients with fair complexions with this. So that is not an uncommon thing to see. But that's typically the case for a lot of drugs. The nice thing about clonidine is we usually can get by with dosing once or twice a day. But here's a good example of how we may be able to modify an effect. We do know that sleepiness and somnolence is a very common effect that we see with it. So sometimes what we can do is we can split the dosage. So what we do is we take a small dose in the morning, and then we take a larger dose at night. So therefore, the larger dose is more likely to produce the sedation. Here we're taking advantage of that once they get to steady state, we keep a pretty steady level in there. But what happens is that this allows us to give a larger dose at night where there's more likely to be the side effects, such as, having us making us too sleepy. So we can use that aspect to, potentially help somebody sleep. But on the other hand, is using a lower dose in the morning, we have less daytime sedation. So in some cases, we can do this. We can break up the dosage. So we take a much larger dose at night and a smaller dose during the day. Or if the person was working at night, then we take a smaller dose at night and a larger dose when they would normally sleep. As I mentioned, clonidine has had a number of unlabeled usages. In particular, we've seen it used for alcohol withdrawal. We've seen it used for methadone and opiate detoxification. It's also been used for in smoking cessation to help reduce the withdrawal. And also in people that are going through menopause that are having this flushing, these hot flushes that may be uncomfortable, is sometimes that it works. Now, these two components up here, and maybe even the smoking cessation, we'll put a question there. We think one of the things that we've learned, and I actually did a little bit of research on this in the lab, but we know that some of these centrally acting drugs can actually interact with the opiadergic system. And so one of the reasons these may work is because the clonidine, one, there's some, like, for example, the detox and the withdrawal does have some autonomic components to it. And so it may be decreasing the autonomic nervous system components. But the other thing is that we do know that clonidine and even methyl-dopa, and there's even some studies that some of the beta blockers, we've done some of the beta blocker studies, that these drugs may actually release endorphins. So one of the reasons that this may be successful is that when you are using these drugs, a big issue could be that that you are actually producing a opiate release, but it is a localized and much lower release, and that may sort of smooth these things out. So that may be the explanation for these benefits of these drugs. We do see a couple of drug interactions. One is that beta blockers, they can cause a withdrawal syndrome. I don't know if has any of y'all heard of the withdrawal syndrome produced with beta blockers? Okay, so we'll talk a little bit about them, but all of the centrally acting drugs, if they're discontinued abruptly, they can actually go through, patients can go through withdrawal syndrome. And one of the big things that we see is that this may be due to this opioid effect. And one of the things that we want to do is that if beta blockers and clonidine are being used, when we taper them off, we want to, or when we take them off the drug, we want to taper them off, and that usually prevents it. There has been some interaction with tricyclic antidepressants that they block the hypotensive effects of clonidine, and so the tricyclics effects aren't messed with, but the tricyclics may actually block the blood pressure lowering effects of clonidine. The next two drugs really are very similar, and I don't have them in red for you because I just wanted you to hear about them. Guanfacine, very similar to clonidine, structurally different, but still binds to the alpha-2 receptor. So mechanism of action is exactly like clonidine. Pharmacokinetically, it has a little longer duration of action. And some people have suggested that it may not produce the same degree of side effects. That's really a I wouldn't necessarily agree with that. We have less people on guanfacine, and so we just may not have the same degree of exposure. I would say that the side effect profile is probably about the same. We have seen this one used for treatment of heroin withdrawal and also used with migraine. And the fact that it has a longer duration of action is probably the reason it can be used over, that it would be used over clonidine. And so those are, in Guanabens, the other drug is very similar. So really what it comes down to, the other clonidine-like drugs, they're going to have pretty much the same side effect profile. We got to worry about somnolence. We got to worry about sexual dysfunction. We got to worry about potentially depression. So both of these drugs also would be concerned. And but generally they're pharmacokinetics, so duration of action and onset is probably the big difference. Now, I mentioned a withdrawal syndrome a minute ago, so let's take a moment to discuss that. And this is important for you guys to know because this can, so if we discontinue any of the CNS acting drugs, whether it's methyldopa, clonidine, guanfacine, guanabens, and even beta blockers, what we see is that there is a withdrawal symptom. The individual goes through very similar to what we would see with morphine withdrawal. Blood pressure goes up. A lot of times, one thing that happens is if you've got a hypertensive patient and you take off the drugs that are maintaining his blood pressure low, then his blood pressure is going to go up. But this instances, the blood pressure goes up higher. These individuals go through a lot of anxiety. They have muscle tremors. Heart rate goes up. They get tachycardia. A lot of excessive CNS activity, very similar to what we see with morphine withdrawal. Typically, this occurs about 18 to 36 hours after stopping the drug. And we believe that this is due to the interaction on these central acting drugs on the opioidergic receptors. And what's happened is that they have been stimulating those. And so when you abruptly withdraw, it's just like going through opioid withdrawal. And naloxone will actually reverse it. The safest thing to do, not everybody that just stops taking their medication will do this, and this is usually not a life-threatening situation. If you have an older person that has a lot of other comorbid conditions on their heart, yes, it's a possibility. But most individuals, this is just very unpleasant. What we typically tell people to do with any of the centrally acting drugs or the beta blockers is that if you're going to stop them, then basically taper it down. So, you can taper it down and go do this over a week to 2 weeks. So what you would do is basically go in to maybe half the dose for a couple of days, and then maybe you could either quarter the dose, or you might go to dosing every other day, or that sort of thing to do that. Joy, from a standpoint of these drugs with ADHD, is that we believe that these are very similar. So these drugs could potentially stimulate receptors up in the brain that would basically, it's the same, sort of the same component, is that they're going to basically increase the inhibitory pathways, which sort of put the brakes on it. And I think I have a paper that describes these, which I will get for you guys on that. And plus, y'all will talk a little bit about it when we talk about ADHD medications in general. But let me get that paper and post it for you. Clonidine was used, or there were some trials with clonidine to try to use with ADHD, and they showed some success, but not to the same degree as they saw with Adderall. But I'll get you, I think I have a paper in one of my folders here that I can pull up pretty quickly. So when we get the next break, I can try to pull that up for you guys. Okay. Let's see. All right. So let's cover, what we're going to do is we'll cover the beta blocking drugs. Then we'll take our last brief, we'll take one more brief break, and then we'll pick back up and maybe try to get through the alpha drugs before we break for lunch. What we'll do is, like we did last time, is I've got 4 questions on the material we've covered this morning, some of the material we've covered this morning, and just like we had before, which you're not going to be graded on, but we will provide the answers when we come back. But these are just the integrated ones. All right. Beta blocking drugs. These could have been covered under autonomic drugs, but I leave them to put under the cardiovascular because it's more indicative. So what we've seen with beta blocking drugs is, it's like a lot of drugs. We started off with the original drugs were what we call non-selective, meaning that they blocked or interacted with multiple receptors. And in fact, that's what we started off with. So the non-selective beta blocking drugs, what they're going to, non-selective means they're going to block beta 1 and beta 2 receptors. Okay. So that's non-selective. All right. And the prototype for this is propranolol and nadolol. We also have timolol, which is available as an antihypertensive drug, which was marketed under Blocadrin. But we also see timolol was marketed for treatment of glaucoma, and the preparation they used for that was called Tim-Optic. We also have another drug which we don't see used a whole lot, which is penbutalol. These were all non-selective drugs, meaning they blocked both beta 1 and beta 2 receptors. Okay. Then what we started seeing is we wanted more selective drugs. So then what we saw was sort of our second generation. We saw what is the drugs that were referred to as beta 1 selective, which meant that these drugs had a higher affinity for the beta 2 receptor, for the beta 1 receptor, and less affinity for the beta 2 receptors. So at low to moderate dosages, we had primarily a beta 1 response and a minimal, if any, beta 2 response until we started getting up to high doses. So one of the problems with the non-selective drugs is that if I wanted to just block the beta 1 receptor, for example, the beta 1 receptor in the heart, these other drugs also block the beta 2 receptor. And so some of the side effects were associated with the beta 2 actions. For example, I don't want to use propranolol in a person with some pulmonary problems because that can block the beta 2 receptors in the bronchioles, which may make it difficult for them to, for the bronchioles to dilate and for them to breathe. So the beta 1 selective drugs, we came out with atenolol, and probably the 2 biggest ones we see used are atenolol and metoprolol. That's why I have them under or highlighted. We see a little bit of acebutolol or metaxolol or bisoprolol, but for the most part, most people are using metoprolol and atenolol. Then the next generation, if you will, we went to what is called drugs with ISA. And the ISA stands for, I'm going to write it down or type it in here, intrinsic sympathomimetic. Activity. Okay. And Carolyn, yes, I'll do that in just a second. So this is ISA. And before I go into that, let me repeat what I just said is, so for example, with propranolol is if I wanted to slow heart rate, I could give propranolol. That would block the beta-1 receptors. But if I had a patient with asthma or COPD that had respiratory problems, then basically what would happen is that I would get beta-2 blockade, which would impair my bronchioles from dilating. So that could create some problems. And so we went to the beta-1 drugs, selective drugs, which meant that we could block the beta-1 receptor and have very little effect, if any, on the beta-2 receptor. Okay. So then we had some drugs, and the best example here is probably Pendolol. These are theoretically beta-1 and beta-2, but they have intrinsic sympathomimetic activity, which means that they sort of stimulate the sympathetic nervous system. And so we don't get as much suppression. So we get beta-1 and beta-2 blockade, but not quite as much as we get. And so that sort of reserves the beta-2 function. And then the fourth generation, which the example I've given you is celiprolol, is the beta blocking drugs. They basically block the beta receptor, but they also have some sort of direct action, which on the blood vessel, they cause vasodilation. So they prevent the vasoconstriction occurring from blocking the beta-2 receptor. So first generation non-selective, second generation was basically the selective drugs. Third generation is we would probably call something like drugs with beta blockers with ancillary properties. So the mechanism of action, although we simplify it and call it beta blockade, it's a little bit more complex than that. So with beta blockade, we know that will decrease cardiac output. It blocks the beta-1 receptor. And when you block the beta-1 receptor, that slows down heart rate, that slows down contractile force, and that's why cardiac output goes down. But the other thing, which when I was at Charleston, this was a big area that we were looking at, is we knew these drugs had what we called adrenergic blocking action. We did a lot of work with propranolol, but I also demonstrated it occurred with some of the other drugs also. But we find that the beta blocker, let's use propranolol as an example, that's where most of the work was done, actually gets taken up into the presynaptic neuron, and it displaces norepinephrine. So the net effect is it reduces the amount of norepinephrine. Then when the nerve fires, it actually will release propranolol. So the net effect is that we see a false transmitter in the sense that it's released, and then the propranolol will bind to the beta receptors once it's released, but it also reduces the amount of norepinephrine that's released. So we have two actions going here. We have that it is decreasing the amount of norepinephrine being released, and it's blocking the beta receptor. The other thing is we know that it acts in the central nervous system, and we produced did some results or did some work with this. One of our papers was published in Science, is that we showed that propranolol can actually interact with opioidergic systems and alpha-2 receptors. Net effect is it also gets into the brain and decreases the sympathetic outflow, which would decrease the amount of norepinephrine and propranolol released. And then we know that through the beta receptor, it can inhibit the renin system. So we would see that it was effective with people that had high renin-angiotensin effects. So it's not just simply beta blockade. I would call the cardiac output effect would be beta blockade, beta-1 primarily. The renin release is beta blockade, but the others may be associated with an interaction with opioid and central nervous system activity. So again, as I said, first generation were non-selective, second generation were selective or more selective than the first generation. And then the third generation have these ancillary properties that either intrinsic sympathomimetic activity, stimulation of the beta-2 receptor, so that would keep bronchodilation active, it keep vasodilation active, or may directly vasodilate the blood vessels. Those are all very positive things. So what we found was the first and second generation drugs, their primary action was decreasing cardiac output, But one of the concerns was they may actually increase total peripheral resistance. They could cause the blood vessels to constrict. How did they do that? If they block the beta 2 receptor, what we saw is that prevents norepinephrine and epinephrine from stimulating the beta 2 receptor on the blood vessel and prevents vasodilation. Most people, this isn't going to be a problem if they're really sedentary. It becomes more of a problem if they're more active. And in fact, one of the things that we see is runners, people that run for exercise, many of them do not like the beta blockers because it slows their heart rate down. And a lot of these runners, they are using their heart rate to determine their fitness. So they don't like that. And the other thing it can do is it can reduce exercise tolerance. So what it means is you can't get your heart rate up as high as you used to when you're on these. A big thing also is if it's got beta 2 blockade actions, by blocking the beta 2 receptors in the bronchioles, that's going to interfere with your exercise because you need to breathe in and your bronchioles can't dilate to accommodate that. So let's look at a couple of these drugs as far as the prototypes. So non-selective, we're going to use propranolol. You guys will probably prescribe propranolol for a few things. Propranolol is highly protein bound, which means there's a potential for drug interactions. And it also goes through first pass metabolism. And remember, first pass metabolism is when the drug goes through the liver the first time, a large portion of it's going to be metabolized. First pass metabolism we don't like because it creates more variability. Okay. Now, propranolol, typically one of the things was the advantage of propranolol is we know the drug really well, and there were a lot of different dosage forms. So you could really tailor the dosage to the patient really well. The downside of it is that it has to be dosed usually 3 to 4 times a day. But they did come out with a Inderal XL, I think it is, which is an extended release. But one of the big problems with propranolol was that basically you had to dose, the patient had to be dosed 3 to 4 times a day. Compliance was an issue. Nadolol came out, and the big thing about Nadolol was it had a long half-life. Nadolol allowed us to dose once a day. Another advantage was that it's not protein bound, so we didn't have the same issue. Timolol was one. We used it to treat glaucoma. Again, it's beta blocker. And then these beta selective agents is when we don't want beta blockade. So we don't want it where that, especially with people with pulmonary problems, and we may not want it in patients that we're concerned about it can cause some vasoconstriction by blocking the beta 2 receptor on the blood vessel. With these beta 1 selective agents it's a function of dose. So we want to keep the dose low to moderate. If we start increasing the dose and getting moderate, high, or high, then we will get some beta blockade. And again, the drugs that we use here is atenolol and metoprolol. The non-selective, just wanted you to be aware of them. Basically, most people believe that you get a partial beta receptor agonism. So it is an antagonist with a partial agonist effect. And when it came out, the one drug was Pendolol when it first came out. And some cardiologists like it because what happens is it doesn't suppress heart rate and cardiac output like the beta blockers do. It's got limited use, but it's still around. And then one of the concerns is with a non-selective beta blocker is the aspect of blocking the beta 2 receptor. And if you block the beta 2 receptor on the blood vessel, that causes the blood vessel to constrict and not dilate. So sometimes we give it to them and we find that they would have this sort of vasoconstrictive effect. So there are drugs, these other drugs either stimulate the beta 2 receptor, or what they do is they have a direct action independent of a receptor to cause vasodilation. And that beta 2 effect is not limited to blood vessels. It also theoretically would be helpful in individuals that had that had pulmonary problems, and you would not want that beta 2 effect um, causing bronchoconstriction. The side effects of the beta blockers are pretty straightforward and are extensions of their pharmacology. And one of the big things we see is too much beta blockade. So what happens is the heart rate goes down too low, so bradycardia. We see blood pressure drops too low. In some patients who are borderline heart failure, by blocking slowing the heart rate down and dropping the blood pressure, you may actually precipitate heart failure. We may get some pulmonary dysfunction where their bronchioles cannot bronchodilate because of the beta 2 blockade. But one of the things on all of these, even though some of these beta blockers are considered not to have too much CNS action, if any at all, but one of the things, propranolol and several of them do have some pretty prominent effects, and we do see depression, nightmares, and insomnia that can occur with those. One of the biggest things we see with patients put on beta blockers is they will complain of fatigue. It doesn't appear to be due to the slowing of the heart rate and so forth. There seems to be some other component there. Don't know exactly what the fatigue is or what's causing the fatigue, but it is well recognized. And then again, as we talked earlier a few minutes ago, if you abruptly discontinue these drugs, then there's a chance, especially if you've been on them for a while, there's a chance of you going through withdrawal. They may exacerbate pulmonary dysfunction. That's due to blockade of beta 2 receptors. And one of the big things that we are very cautious about using these is in diabetics. When diabetics develop hypoglycemia, one of the symptoms that they learn to recognize is basically they learn to recognize the autonomic effects. The heart rate speeds up and so forth. And when you've got a beta blocker, they may not recognize that because that doesn't occur. So we have to be very careful about using these in diabetics for that particular reason. Okay, let's take our last break this morning. So let's come back at, let's come back at about quarter after. And then we will finish up the mixed blocking agents and probably the alpha agents, and then I'll let you guys go for your test. Do your test. We'll give you about 15 or 20 minutes to do those 4 questions, okay? All right, so I'll see you guys at quarter after. Okay, guys. So what I want to do is I'm going to skip a few slides. I'm going to skip forward a few slides. And the reason for it is because I want to cover the alpha blocking drugs and then come back and talk about these mixed blocking drugs. So let's skip ahead about 2 slides. So the alpha, and so we've finished talking about the beta blockers. Okay, so now we're going to talk about the alpha blockers. And we actually have 3 drugs that are on the market that are considered alpha blockers. We have prazosin, which was originally marketed as Minipress, and then we've had terazosin and doxazosin, which are the 2 newest drugs. But all of them are acting the same way, and what they're doing is they are selective blockers of the alpha-1 receptor. Okay, this is it, alpha-1 receptors, and again, selective blockade. Now, we had a drug several years ago called phenoxybenzamine that was out, and there was 2 things with the phenoxybenzamine. Number one is phenoxybenzamine blocked alpha-1 and alpha-2 receptors. But the other thing about phenoxybenzamine, whereas all the drugs we've talked about in this course so far have all been competitive blockers, phenoxybenzamine was an irreversible or a covalent blocker, which means that pretty much it cemented itself to the alpha-1 and alpha-2 receptors, so it was permanent. And that permanent blockade and the alpha-1 and alpha-2 actions actually created a side effect profile. It dropped blood pressure, and basically it was hard to recover from, and it just really was very difficult to use. So the alpha blockers sort of went out of favor because the drugs we had were like that. And so then what happened is we had a drug that came up, which was called, which prazosin came on the market, which was a specific or a selective alpha-1 receptor blockade. And it was also reversible. Okay. So these early agents like phenoxybenzamine, and there was another one which I'm drawing a blank on, they were all non-selective, and we had a lot of problems. It dropped blood pressure too low, and it created a lot of tachycardia. But by going to these selective blockades, we were able to use them. And so prazosin is very highly protein bound, so we have to worry about drug interactions. Terazosin actually lasted a little longer than prazosin, but it seemed to not produce as much of the postural hypotension. Now, all of these alpha blockers that are reversible and selective have, and doxazosin was the third one. And again, the biggest difference between the 3 drugs there was they were all, the common thing, they all act the same mechanism. The differences really came into the pharmacokinetics, so the duration of action and the bioavailability and so forth. So what happens is by blocking the alpha-1 receptor, that causes vasodilation. Okay, that's their main mechanism for producing, as acting as an antihypertensive. And so the mechanism is the same. They block alpha-1 receptors. The alpha-1 receptors on the blood vessel. When the alpha-1 receptor is stimulated by norepinephrine, it causes vasoconstriction. Prazosin, terazosin, doxazosin, they all block the alpha-1 receptor. That prevents the norepinephrine from binding, and we get vasodilation. Now, the biggest problem with these drugs were that they were really sort of real effective at dropping blood pressure. And in fact, the most common side effect was due to excessive or too much vasodilation. Blood pressure dropped too much. In fact, when we first came out with prazosin, when we were going to put somebody on prazosin, we would actually put them in the hospital. Because we would taper the dose a little bit. And one of the things that we saw was there was a thing called let's see if I got it on the next slide. Yes, we had what is called the first dose effect. Notice it's first dose. That is not first pass. So this first dose described when we gave these alpha blockers, they would drop blood pressure so much that the individuals would get dizzy, the heart rate would speed up, and potentially faint. And so what happens is that the blood pressure dropped, plus the veins vasodilated, which decreased the amount of blood coming to the heart. So the first dose effect is different than the first pass effect. Don't confuse the two. First pass is dealing with metabolism. First dose means with the first dose, there was an excessive response, okay? So what we learned is by lowering the dosages and being a little bit more cognizant of these effects, we found that you can start people on prazosin and they do fine. But again, the mechanism of action is the same. It's alpha-1 blockade. The side effects are primarily due to excessive vasodilation. Postural hypotension or orthostatic hypotension is pretty common. It's probably the most common side effect, and that's related to the dose. It's dose related. So the larger dose, the more effect you get. If a person is fasting, if a person is standing up, if they're on a low sodium diet, if they're on a beta blocker, or they're dehydrated, they're going to be more susceptible to this because you're changing the blood volume or you're changing the ability of the body to respond to that. So what we learned is by starting them off on low dose, making sure they're hydrated, and these other things, that we can start people on prazosin and we don't have to hospitalize them. But again, some other side effects that we see, headaches can be due to the vasodilation, but we do see some drowsiness and fatigue. Some people think the fatigue, there's arguments as to, some people think the drowsiness and fatigue may be due to a central action of the drug. Some people argue that it may be just due to the cardiovascular system. We're not going to worry about the mechanism. What we're going to just really look at is that, it's alpha blockade, and excessive alpha blockade can create a problem. So one of the things we do is, to avoid the first dose effect, we start with a low initial dose and we increase it over 2 weeks. Whereas when we first started using the drug, we were using higher initial doses. We kept them in the hospital overnight, and then we sort of got them maintained. Another thing that we've done is that we can divide the dose so that we use a small dose during the day when you're up and about, so you don't have to worry so much about orthostatic hypotension and dizziness and so forth. And we give you a higher dose right before bedtime. And so before bedtime, you're sleeping, so you're not getting up and so forth. One of the things that we do see, there's not a lot of drug interactions that have been reported. We do know that since it can cause hypotension, any other drug that may lower blood pressure, that you may have a greater effect. Now, one of the things you need to be aware of is some of the drugs that you use can lower blood pressure. That's not their main mechanism. But if you're using any other drug that may potentially lower blood pressure and they're on prazosin or one of these alpha antagonists, you need to be aware of it and maybe start with low doses or warn the patient. This drug has also been used for treatment of benign prostatic hyperplasia. This occurs in men over the age of 50, where the prostate tends to be increasing and in size, which makes it difficult for them to urinate. And so this has been effective there, and I think it's actually approved for it. But we're also seeing prazosin, and in particular prazosin, being used for some other things like involved with PTSD and nightmares, which y'all will go into in much more detail when you get to that portion of the course in the advanced course. Now, let's go back. So we've talked about beta blockers. We've talked about alpha blockers, okay? So we do have a few drugs which we refer to as the mixed blocking agents. What the mixed blocking agents do is they're really going to combine alpha-1 and beta-1 blockade. So here's the key point. They are going to have alpha-1 properties, alpha-1 blockade properties, so going to be prazosin-like, and they're going to be beta-1 blockers, so it's going to be similar to metoprolol. So it's almost like taking prazosin and metoprolol and putting them together, okay? The drug that we see, two drugs that have these capabilities. One is called labetalol, and labetalol was marketed really as under two trade names. One was Normodyne, the other was Transdate. And then we have a drug called carvedilol, okay? So of these, labetalol is probably the most commonly used. So the way that they lower blood pressure is that if you decrease heart rate and cardiac output, so that will cause your blood pressure to go down. And they do this by the beta-1 blockade. And at the same time is they cause the blood vessels to vasodilate. So that's what causes the decreased TPR, total peripheral resistance. And that's done by alpha blockade. So what they're going to do is they're going to slow the heart rate and decrease contractile force, and they're going to vasodilate. Okay. So the combination of alpha 1 and beta 1, you're acting through two different actions or two different sites to lower blood pressure. Typically, the bradycardia, that slowing of the heart rate, it does occur, but it's not as bad as with just the same beta blockers. And the reason probably for that is, think about this. When you drop blood pressure by alpha 1 blockade, remember the reflexes we talked about? So what happens is when blood pressure drops, your body tries to raise blood pressure back up to where its set point was, and it stimulates the heart to try to speed up. But we have a beta blocker there, which is slowing that down. So what we're seeing is the effects of the alpha 1 blockade activating reflexes helps to prevent bradycardia. So we don't get too much of a heart rate. We do see some orthostatic. Okay. So it's like, Rebecca, it's like combining the actions of like propranolol, or no, I'm sorry, let's use metoprolol. Metoprolol is a beta 1 specific drug, and prazosin, which is an alpha 1 specific. So you're getting the sort of like the best of both worlds. You're getting beta blockade and alpha blockade. And so the net effect is the beta blockade decreases the effects of the heart. The alpha blockade causes the blood vessels to vasodilate. Okay. Now, just like all the other drugs we've talked about, it does or has the potential for producing orthostatic hypotension. But that occurs initially, but it actually, it occurs initially, and it occurs especially at high dosages. But what you find is that it doesn't seem to be as bad. So that's a very positive thing. The beta blocker and the alpha blocker will produce orthostatic hypotension, but again, the alpha blocker stimulates the heart rate by dropping blood pressure. We do have to be careful, and this is true with any of the alpha or beta blockers, is warm temperatures causes your blood vessels to try to cool you off, so blood gets shifted to your skin and the blood vessels vasodilate. So warm temperatures, you may have more orthostatic hypotension, but that's true for a lot of the other drugs also. And so what we see is carvedilol is basically, it is an alpha 1 antagonist, but it's not as selective. Labetalol is a selective beta, where carvedilol is a non-selective. It has beta 1 and beta 2 actions. You don't have to worry about dosages. But the biggest problem by being non-selective beta blockade, the alpha 1 actions offset any of the beta 2 blockade in the blood vessels, but the alpha 1 agonists are not going to, the alpha 1 effects are not going to offset the effects on the bronchioles. So that's the big difference there. So labetalol is probably used more frequently. Carvedilol is the newer drug, but labetalol is probably used more frequently, mainly because of its selective beta 1 blockade. Okay. So, and we talked about the alpha antagonist. So what we'll do is, and Marissa, you can go ahead and get the questions set up for the 4 questions with regard to on this morning's material, and we will talk about the 4 questions with regard to. I'll go over those when we get back after lunch. So now's a good time for break for lunch, and what we'll do is Marissa will put the questions up. So if you guys will take this morning's brief quiz of 4 questions, look back over this material at lunch. I'm not going to give you an additional assignment or anything. I may give you a couple of things to look at tonight, but look back over. I want you to be comfortable. We've covered everything from diuretics all the way through the beta and alpha antagonist and the mixed agents. This afternoon, we'll pick up on sympatholytics, and we'll talk about some of the ACE inhibitors. I do have a case I'm going to go over with you probably this afternoon, or I may give it to you this evening. I don't know. But look over what we've covered this morning and make sure you're comfortable with it. And then this afternoon, we'll pick back up on the sympatholytics and cover through several of we're not going to get through all of the cardiovascular drugs this afternoon. So we'll pick those up in this morning. The other thing is, I thought about putting some additional drugs, but I'm trying to parse this out so that you guys are not buried, because we are dealing with such a large number of drugs. Next time we meet, we'll be talking about the GI drugs. The following week, we'll be talking about GI drugs and sort of hormonal drugs and those type of things. So we'll have another things, but this is an awful lot of drugs. And these are some drugs that you guys will see in your patients. Does anybody have any question before I let Marissa put the quiz up? All right, so I'm going to sign off. Marissa, if you'll put the quiz up, and then we'll go over the answers to the 4 questions when we come back from lunch. You guys have a good lunch, and I will see you at 1 o'clock.